Welcome to London Valves PCR 2023. My name is Hendrik Treede. I'm a cardiac surgeon from Mainz in Germany, and it's my distinct pleasure to be here with two esteemed colleagues. One is Mike Reardon. He's working as a cardiac surgeon in Houston at the Methodists. And the other one is Joao Cavalcante. He's an echo specialist working in Minneapolis. And our topic today is to speak about the treatment of aortic regurgitation, surgical treatment as well as transcatheter-based treatment. And this is an important topic that now came more into focus since we have dedicated devices on the transcatheter side to treat such diseases. But Mike, why don't we start with you? There is kind of a gold standard for the treatment of aortic regurgitation. And can you tell us a bit about the surgical side of it?
Yeah. So although we're trialing catheter valves for aortic insufficiency, surgery is still the gold standard. It's the gold standard for several reasons. Number one, we've never tested anything against surgery. And number two, many of these valves we can repair. And it's always better to have your own valve than a prosthetic valve. So at the current time, surgery remains the gold standard.
Yeah. And can I dive deeper into that? You speak about repair, but what is the reality of repair? If you really look at the numbers that being repaired was to replace, is that really a significant number?
So repair is much like the Ross procedure. When it works, it's the optimum thing. But there are not many real good repair surgeons out there, just like there's not a lot of good Ross repair surgeons. So I'd say there's probably 5% of the cardiac surgical sites or less are doing good aortic valve repair. But in the right center, that's an option that patients still have that when done right, really can return you to the normal population curve. But it's still, as you mentioned, a vast minority of what's being done by surgeons.
And Joao, sometimes it's difficult to really decide on the degree of AR. Can you give us some insights? What's the difficulty behind it? Why is echo imaging so difficult?
Yeah, aortic regurgitation is a growing issue now that we're starting to face, now that we have available transcatheter therapies, and I think we need to bring the disease awareness. The jet eccentricity is one that makes it very challenging, right? So a lot of these patients might have bicuspid aortic valves, younger patients, there's aortopathy. When that jet comes and it hits the wall of the aorta of the left atrium or the anterior mitral valve leaflet, it becomes very challenging for us to be precise, to do the measurements like, say, PISA or the vena contracta width. And what we have observed through several other registries is that aortic regurgitation tends to be undercalled. So by the time somebody calls severe, it probably has been severe for quite some time. The ventricle is feeling it, but eventually we're going to say, now the patient has symptoms of severe, please do something. Can we go upstream? Can we develop ways that we could identify this problem earlier? And that lies the opportunity for us to use cross-sectional imaging, particularly MRI, because it's quantification. And I would say even more CT as well, because CT, we need to do that for the planning. Why not use that also as another metric that we could utilize?
Yeah.
What do you think, Mike? I mean, are we underdiagnosing these patients?
We're both underdiagnosing and undertreating this. I've had several patients in the last couple of months that have come to me with EFs of 20 to 25% who've been followed for many years with aortic insufficiency, totally asymptomatic. And in between yearly visits, they went from EFs that were normal to really bad EFs. And we're still just beginning to have symptoms. So I think that we underdiagnose and we undertreat.
And I completely agree with that. And one reason for this is that for a long time, we didn't have dedicated devices to treat AR. And with the conventional devices, there have been some difficulties. Maybe you can dive a little deeper into that. What have been the difficulties of the conventional self-expanding or balloon-expanding platforms in treating AR?
Well, our conventional TAVI devices are all designed to have something rigid to hang on to, usually calcium, or if it was inside an old porcine root or something, the scarring of the root. But if you have pure AR, you have an annulus that, as you know as a surgeon, is very distensible. And you put a valve in there and it expands out, but then the annulus tends to get bigger and all the pressure's down, and the next thing you know, you have your valve in your ventricle and you've taken something that was elective or semi-elective and made it into an emergency. So the dedicated devices are all designed differently. They have feet that come in and sit in the sinuses. They clip to the leaflets. They can't go into the ventricle if you position them right. So I think there's some exciting transcatheter valves coming open for patients that really aren't good for surgery. But as we mentioned, right now surgery still remains the gold standard.
Absolutely. And these new devices that we see, what do they do different compared to the older ones?
Yeah, so they have the same principles of being able to obviously take care of the aortic regurgitation through a transfemoral route. With, as Dr. Reardon mentioned, they have the capability to be very nicely commissural aligned because you have markers that can identify and clip this leaflet. Since we don't have calcium to hold up the valve, the degree of oversizing, because now we're going to be clipping, might need to be probably way less than what we use for aortic stenosis. That's one learning that we're starting to understand, because that might be some translation to pacemaker and other things that we don't want these patients to have. So they will clip leaflets. They will avoid, obviously, addressing the problem of the commissural alignment, because you need to be aligned to do so. The other thing, too, is obviously the matrix of these devices needs to be probably changed in comparison to what we use for aortic stenosis, right? A lot of these patients have, as Dr. Reardon mentioned, adaptation and dilation of the annulus, dilation of the sinuses, sometimes dilation of even the aorta. But all these devices have to have a larger size to accommodate the treatability of these patients.
I think one of the things about AI that's a little bit different is it tends to occur in younger patients in bigger annuluses. Yeah. So those are people that are often still good for surgery, and we like to operate on as surgeons because if we're going to do a valve replacement, we're going to put in a big valve. But the older patients, yes, many are coming to me and their annulus is out of size for the currently available transcatheter devices. Bigger devices are currently being designed, should be being trialed within this year. So I think there's some encouraging news in the transcatheter area for aortic insufficiency.
Yeah. So that's a good segue to my next question, actually. So now we have to decide, which patient gets which treatment. Are they now all being treated transcatheter-wise, or still room for surgery? And what do we do about bicuspids? What do we do about patients who have aortopathies? So what is your take on that?
I think, there are two big groups of patients, like Dr. Reardon mentioned. You got these young patients that, they should be continue to be screened and followed. They're going to have the capacity to adapt to that volume load for quite some time. When surgery is the right time for them, both fields are going to win, the surgical field, the patients, and the transcatheter, the interventional cardiologist. Then you have this older population that, subjecting them to surgery. Yes, it's still possible, some of them, but if you have an elegant way to take care of the problem, I think that could be a way, right?
We'll start, as we always do, with higher risk patients and develop the data. And once we have the data that supports the higher risk patients, then we'll move down the risk scale as we go along. And of course, there's certain patients that you and I see, such as people on LVADs that have AI, that we definitely don't want to operate on. And having a transcatheter approach to these people is going to be a huge advance for the patients and for us as surgeons.
Yeah. So the glimpse into the future would be that we see more patients that need treatment. We have better diagnostics. We find them earlier and more of them. And then we have a bunch of treatment options to take. Or is there anything else you expect to come in this regard of aortic regurgitation?
Well, I just think we're going to define the field better. Right now, I think it's an underserved field because so many of them are asymptomatic. And many of the family practice doctors and the general cardiologists say, well, I've looked at it, it looks moderate. They don't do anything besides an echo. It may be severe. Yeah. And they don't really understand the echo diameters very often. But as long as the patient doesn't have symptoms, they follow them. Mm-hmm. And then you and I see them when their ventricle is 6.5 or 7 and their EF has already fallen. And we know even if we fix those patients, they'll never do as well. So I think the future is we're going to diagnose this earlier and we're going to consider treatment earlier.
And that's the exciting part, right? We're going to move now. It used to be that TR was the forgotten valve. AR is starting to become a little bit known. We're going to build disease awareness and move the goalpost, right? The guidelines are outdated. They served us well, but now it's time for us to change. And with these iteration devices and more independent research, we're going to continue to do that and serve better these patients.
Okay, so thank you very much, Mike and Joao. That was a great discussion. I think it's really much going on in this field right now. The new devices coming up. I hope we have that in our hands soon from now. One device is CE marked already, but there's more to come. And definitely we'll hear more about this in the near future.